really gives me great pleasure to introduce my dear friend, Dr. Majid Aziz, who's a consultant pediatric neurologist who works in Sheikh Khalifa Medical City in Abu Dhabi for the last couple of years. And Dr. Majid had finished all his basic and advanced training in the UK and in Australia. And as per the bio that was provided to me here, and I know that for a fact, Dr. Majid has so many interests within pediatric neurology. He's a well-seasoned epileptologist. He's very much into movement disorders. He's very much into EEG and stroke, and the list just goes on and on and on. So without further ado, it gives me great pleasure to introduce Dr. Majid Aziz, who's going to shed light on how to manage epilepsy in the group of children with cerebral palsy. Thank you.
Thank you. Assalamu alaikum. Good morning, everyone. And thank you, Mohammed, for the very kind introduction. And we really cherish our long association and friendship. And another thank you to Dr. Tariq for his kind invitation for this event. So my task for the next 20 minutes is just to give you a sort of a snippet on the epilepsy side of the cerebral palsy. This is not an uncommon comorbidity that we all see as pediatricians, as neurologists, as rehab clinicians. Better? Thank you. If you look at the definition of cerebral palsy, this has evolved over the course of time. It looks at from which lens you look at. And the definition sort of evolved over the time. If you were a rehab consultant, if you were an orthopedic surgeon managing these kids, if you were a neurologist, or if you were a general pediatrician, or in the UK, if you were a neurodevelopmental pediatrician or a community pediatrician, the things sort of evolved, and you looked at from the lens that it was mainly a problem of movement and posture. But thankfully, some intelligent people sat down over a couple of, about a decade more than that, and they decided that the comorbidities carry an equal burden, and it's not just a problem of just movement and posture. So your comorbidities, and particularly epilepsy, was made as part of the definition. And when we talk of epilepsy as a basic term, a simple definition would be that if you have 2 or more unprovoked seizures, and elicited by synchronous neuronal activity, synchronized activity, leading to the excessive firing of those neurons. Now, we've talked about this concept in the last couple of days, and you've listened yesterday afternoon and this morning, that the brain development, the timing of the injury is very key. So your first 20 weeks of your development is where your neuronal proliferation is happening, the migration is happening, and after that, your neuromodulation, your synaptogenesis, and that continues even up to the post-term region. And so if the insult happens prior to your proliferation, you'll get a different form of brain injury, developmental problems. And if it happens later on in the postnatal or in the perinatal, the spectrum of problems that you're going to face with these children will be different. We've listened to this in different presentations in terms of, what is the risk factors, what are the distribution of etiology in terms of the prenatal, the postnatal, and the neonatal problems. And I'm not going to go into the details because other speakers have highlighted these risk factors in detail. I'll highlight what is the distribution of epilepsy, or the prevalence of epilepsy in terms of cerebral palsy. Now, unfortunately, the data is very much lacking in this part of the world. And if you look at the registries, the cerebral palsy registries from Europe, and this is looking over a course of from 1989 to 1976 to 1998, over 17 registries across Europe. And what they've highlighted is that the prevalence of epilepsy is nearly in about 1/3 of the cases. And with different studies, the spectrum varies for nearly up to half of the cases that we see. And when this study was being undertaken, these registries, the data were collected, nearly 2/3 of the patients were already taking anti-seizure medications. And interestingly, just to highlight to you that despite, over a decade or 2 decades, the prevalence of epilepsy in terms of the type of motor problem, the kind of etiology or the presentation hasn't changed. There's been slight fluctuation, but in terms of the prevalence or the incidence of cerebral palsy, it hasn't changed over the course of years. Now, if you look at the distribution of epilepsy in terms of your motor problems, then which group of patients or pediatric group is much at higher risk of developing epilepsy? So the basic rule is that children who have sort of bilateral cerebral palsy or quadriplegic cerebral palsy, and they're unable to walk, have the high risk of developing epilepsy. And this is to just highlight, if you can see that, if you have bilateral cerebral palsy with difficulty to walk and you're not ambulating, you're at much higher risk compared to children who have a unilateral spastic diplegia, hemiplegia, or even if you have a bilateral diplegia, but you're still able to walk, the risk is much, much lower. In terms of the etiology, again, it depends very much where we've highlighted the time of injury to the brain. So if you are born with a congenital malformation, or you've had antenatal injury to the brain, then you're at a much higher risk of developing epilepsy or a bad epileptic encephalopathy compared to if you develop a postnatal injury, which is more focal, then your distribution and difficulties would be very limited. And again, in terms of the commonest presentation that we see, like the periventricular, if you have a stroke, if you have periventricular leukomalacia, if you have congenital CNS malformation, or a spectrum of different etiologies, then we can see that the distribution varies among them. And even though PVL, we call it a white matter injury, but there is high risk of developing epilepsy in these patient groups as well. Now, if you're faced with a child, how would you determine that, which is the group of child which is at high risk of developing epilepsy, and what would be the age of onset among this group? So we usually see epilepsy onset within the first 4 years of children who have been diagnosed correctly with cerebral palsy. And we listened to a lot of colleagues this morning about the mimics and how to be making sure that we make the right diagnosis and not to miss out the mimics of cerebral palsy. If it's an early onset, usually they have neonatal onset seizures, they have CNS malformation or injury on their MR imaging, and they have severe motor impairment, like we said. Very rarely, epilepsy would develop after 6 years of age, and we rarely see adult population developing new onset epilepsy who have a diagnosis of cerebral palsy. We are all very familiar with this diagram. So this is the ILE classification of epilepsies and epilepsy syndromes. And we follow the 5 axes when we are dealing with a child who comes to our clinic or in the ED with an event, what we classify as an epileptic event. So you go through these 5 axes, you define what kind of seizure it is, you determine that does the pattern fit with a particular age group, particularly signature on the EEG, and can we define it within the epilepsy syndrome? And again, looking at the etiology, what is contributing to these difficulties and the comorbidities. And cerebral palsy, as we've said, it's an umbrella term, it's cerebral palsies. And same thing, we don't call things as epilepsy, and there are epilepsies. So all types of epilepsies do exist in children with cerebral palsy, not one single type, and you'll see multiple seizure types within the same patient or in the same distribution according to age type. They may start with infantile spasms, they may evolve into Lennox-Gastaut syndrome, they may present with simple age-limiting type of epilepsy. So all different types of epilepsies, different type of seizure patterns can exist in the same child or in a child with cerebral palsy. So they do not have a particular pattern. It may be very similar to what we see in our common patients with epilepsy in other etiological groups. This is just a snippet to give you the different types of epilepsies that we come across in children with epilepsy. And there haven't been much longitudinal studies because there's been different ways of classifying epilepsies among children with cerebral palsy, how you interpret the EEGs. And you can see that a big chunk of diagnosis is center temporal spikes or children with Rolandic epilepsy or self-limiting type of epilepsy. And the other thing you highlight and note is that there's a lot of overlap, in a same child may present with early onset seizure, but later on the seizure will disappear and will present with, just this age limiting type of epilepsy, or, may evolve into an epileptic encephalopathy. And this is, a study of 41 children from the UK who were followed up over a course of time following an event, in sort of cerebral injury, both in the prenatal or in neonatal period, followed up over a course of time. And this was the spectrum of seizures that we were getting and the type of epilepsies that we had. Some of the commonest ones that we see, so, dealing with children with infantile spasm, again, a very common entity for us pediatricians and neurologists. And the incidence is about up to a quarter. So different studies have quoted between 10 to 25, 26%. And again, it's not very specific whether it would happen more in the spastic quadriplegics or the hemiplegics or the diplegics or the dyskinetic one or the type of injury. So it's, again, as we know, infantile spasm is of multivariate etiology, and they can present in even any type of cerebral palsy, and it's not very specific to one single type of brain injury. Again, they respond to medication very well, age remission, but if they've had extensive injury, if there was onset of neonatal seizures, then there are very high risk of remission of these spasms in this particular group. Now, early infantile epileptic encephalopathies, developmental epileptic encephalopathies, you may have heard of the terms of Ohtahara syndrome and early myoclonic epilepsies, but now with the new classification, with the new definition, it has been replaced by epileptic encephalopathy and developmental epileptic encephalopathies. And these, again, are structural abnormalities like polymicrogyria, hemimegalencephaly. If the child has had stroke, these will present with early onset neonatal seizures, very difficult birth suppression pattern, tonic and myoclonic seizures, very difficult to control. And sometimes they will sort of evolve from Ohtahara syndrome or developmental epileptic encephalopathy, within a few months go into infantile spasms, and then a few months later land up in Lennox-Gastaut syndrome. So this is a symptomatic generalized type of epilepsy where you have particular seizure type. It has a particular pattern to the EEG. It's an electroclinical syndrome, not a specific type or a diagnostic. And again, we deal with a lot of genetic epilepsies, metabolic epilepsies, which can evolve in a very similar way. So this is to just highlight that cerebral palsy is not different from any other etiological condition that we deal with epilepsy, and the spectrum and the pattern of changes that we see is pretty common. One thing, again, to highlight, we often see this scenario that patients being sent to us in clinic where they've gone and somebody has done an EEG and their sleep activation of their central temporal spikes or EEG spikes and been given a diagnosis of epilepsy. And this is something, again, to highlight. So this used to be called ESES or CSWS, but now, it's an epileptic encephalopathy with slow spike wave activation during sleep. So this is a very common phenomena. If you've had a structural abnormality, for example, if you have bilateral polymicrogyria, if you've had a stroke, if you had, HIE, most of these kids will have a lot of abnormalities. And sometimes they are over-interpreted. But again, interpreted in the context of, now, if a child with cerebral palsy has presented to you with sudden cognitive decline, with language decline, with new onset type of seizure or motor decline, then this is something to be mindful about. And yes, doing a sleep EEG would help you determine that the child hasn't gone into this ESES sort of pattern because it has a particular treatment pattern start to it. And again, looking through the studies, how people are interpreting the EEGs, the incidence can range from anywhere between 10% to 60%. So again, it's very dependent on the clinician, what they're identifying, what they're interpreting these changes. A few years back, we used to call at least 85% of burden on the EEG, but now that concept has been taken away. So if you have most of the sleep EEG pattern with slow spike wave activity, you have to be very careful and not interpret it in the wrong direction, like in LGS. Now, your question is, you're seeing this child, how you're going to determine, is this child going to do well? What is the long-term outcome? And there are three basic concepts. One is, what is the type of injury? Now, in the beginning, I said to you that quadriplegics, diplegics do badly, but hemiplegics go well. Now, this study highlights, which is from Japan, because this is the only study that have followed these people up to their 50s to see how their epilepsy has evolved. And if you see the top width, it tells you that the hemiplegics haven't done that good. But if you look at the pediatric few of the studies, which are very limited, the hemiplegics do well, whereas the bilateral bilateral spastic CPs or the diplegics and the dyskinetics, they do well. The other thing to highlight in all three scenarios, there's a very early onset, their seizures begin within the first couple of years of life. But if you see over a course of time, by the time they hit 20s, the seizure sort of improves in majority of the children. And that is what we see also in our clinics, that children who've had, stroke, who've had, HIE, over a course of time, their seizure burden, burns out. Whether it's the brain burning out, it hasn't got the juice enough left in it, no energy left in the brain to make more seizures. But as you can see, that the seizure pattern does improve over a course of time. And the second thing is that if you have mild learning difficulty or profound learning difficulty, then you're also at a risk of having ongoing seizures and needing long-term epilepsy treatment. And lastly, if you have a clear lesion on the MRI brain, extensive injury to the brain, then you're at high risk of having ongoing epilepsy. This has been discussed about early this morning about the imitators, and I won't go into the details, but again, to be highlighted that a lot of these children have associated movement problems, often interpreted as seizures, and sometimes wrongly diagnosed and started on anti-seizure medication. So we see this often referred to us with non-epileptic staring, a lot of behavior, psychogenic movements, a lot of, choreathetoid movement, a lot of myoclonic jerks, a lot of tremulous movements, dystonia. They can all present with as mimics of seizures, and we've already sort of listened to these in the morning. Again, I cannot emphasize less on this concept that EEG is a tool. It helps you with the diagnosis, but it doesn't help you to make the diagnosis of epilepsy in children with epilepsy. So often, they come to ED, they come to clinic, and our first reaction is, we'll get an EEG on this child, not knowing whether the event, the history fits with a clinical event that can be described under an epileptic seizure. And we know that 60, 70% of these children will have abnormal EEGs and will be wrongly interpreted, and this child will be given anti-seizure medication, and sometimes will make their behavior worse. A number of times we've seen that they've gone to clinics or to EDs or other private hospitals, certain ones, and what happens is that they're put on Keppra. The child already has a lot of developmental difficulties, learning problems, behavior problems, and it gets worse. And what the diagnosis is, never had a seizure, but an EEG was done and picked up changes. And there are particular patterns that we see, like hypsarrhythmia. You can get generalized spike wave discharges. And as I highlighted to you, that the Rolandic kind of EEG pattern, the central triple spikes, again, very common in children with cerebral palsy and has to be interpreted very carefully. If it's questionable, admit them, do video EEG, capture the events, and come to the right diagnosis. Treatment, it's a whole big talk, may take hours and hours and days of discussion, but the treatment pattern that we use for children with cerebral palsy is no different from any other child that we would be seeing for epilepsy treatment. So they would involve basic rules when we choose anti-seizure medication, preferably monotherapy. If you have to use polytherapy, then avoid adding too many drugs, use drugs that do not interact with one another, look at their adverse side effect profile, build up slowly based on what the seizure response is and their side effect profile. Often we see children being loaded with more and more medication because the aim is to stop the seizure, and rather than benefiting, it causes more side effects. Ketogenic diet, again, a whole topic on its own. And if there's a child which has a structural abnormality, very clear in non functional area, or hasn't got a much deficit, then it's recommended to put them to the early epilepsy surgery program, because that can render them seizure free and coming off the medication. So in just summary, epilepsy is a very common comorbidity. We see it day in and out with our children with cerebral palsy. The incidence can vary, as I've shown you, among the different types and patterns of injury, because the etiology is multifocal. As we've highlighted that we don't call it as cerebral palsy, it should be cerebral palsies, like we call not epilepsy, but different epilepsies. They all exist in our patient group. And most importantly, again, the message is to use the EEG tool very carefully. And the 3 common risk factors that you're going to tell you that this child is going to have ongoing seizures. They've had neonatal seizure, the seizure onset was under 1 year of age, and they have a structural abnormality. Thank you for your time.